Good evening. Welcome to the New England Hemophilia Association's virtual town hall this evening about COVID-19 and bleeding disorders. My name is Rich Bazzillo and I'm NEHA's Executive Director. I'll be the moderator for tonight's platform. As we navigate the current health crisis together, our primary concern at NEHA is the health and wellness of the individuals, families, and communities that we serve. In this unprecedented moment, being connected with each other is more important than ever. While we may be practicing social distancing, staying healthy means not falling into an unhealthy pattern of social isolation. Our goal at NEHA is to keep you as informed as possible. That's why we launched a new series called Webinar Wednesday. For the foreseeable future, NEHA is hosting a webinar every Wednesday night at 7 p.m. Eastern Time about a variety of topics applicable to the bleeding disorder community. Our first one this evening is a town hall format in partnership with Tufts. Our speakers this evening are Dr. H. Cody Meissner, Chief of the Division of Infectious Disease, and Dr. Cathy Rosenfield, Hematologist and Associate Professor of Pediatrics at Tufts Floating Hospital. They will both facilitate the discussion and take questions from you. In addition, we invited Miriam Goldstein, Director of Policy at the Hemophilia Federation of America, to help answer any questions about treatment supply or insurance questions that you may have. Before we get started tonight, I'd like to go over a few pointers. Tonight's platform will last approximately 1 hour. We welcome your participation and questions. Your audio will be muted by the system for the duration of the webinar. However, if you have a question, we encourage you to use the question box on the bottom right-hand side of your control panel. Again, there is a question box in the bottom right-hand side of your GoToWebinar control panel that at any time you can type in the question. I will then pass these questions along to the panelists once they are done speaking. Before I turn the presentation over to Dr. Meissner, we're going to ask some poll questions. So you're going to need your cell phones for this. So the first poll question is we're just going to do a test. You're going to text 781-412-7971. And the first question is, what's your favorite pizza topping? Text 1 for cheese, text 2 for pepperoni, text 3 for sausage, text 4 for mushroom, 5 for black olives, and 6, my favorite topping is not listed. So for those on the phone, it is a tight match between cheese and my favorite topping is not listed. My favorite topping is not listed is definitely the winner here. So I'm hoping there's other Hawaiian pizza fans that like that pineapple and ham, as that's not listed. So we're going to go on to the next question. This question is a mental health check-in. We know that there's a lot of families that are home with their kids right now, that are out of work. So we want to ask, where are you? Text 1, I'm doing really good. Text 2, I'm doing pretty good. Text 3, I'm doing okay. Text 4, I'm struggling. Text 5, I'm having a really hard time. And text 6, I need to reach out for support. We'll give it a couple of seconds to see where everyone is. Again, there's no right or wrong answer for this. It looks like number 3, I'm doing okay, I guess, with 50%, followed by I'm doing pretty good at 34%. 8% is I'm doing really great, and 4% is I'm starting to struggle. The next question, what is your current level of understanding about COVID-19? Text 1 for very confused, text 2 for confused, text 3 of somewhere in the middle, text 4 for informed, or text 5 for very informed. We'll give this a couple of seconds as the poll is being updated here. Very interesting. So it looks like right now for those that are calling in, 4, informed, has 52%, followed by somewhere in the middle at 20%, and then 5 is very informed. So 54% of you are saying that you feel very informed right now about your level of understanding about COVID-19. And this is going to be the last poll question that we have before we turn it over. Where are you getting your information about COVID-19? This is a little bit different. You can text the information in, and it's going to create a word bubble, a word cloud. So you can text, whether it's social media, whether it's a news outlet, yep, as you can see right now, we have Fox News, CDC. The terms that are the largest are the ones that are being said over and over again. So we'll give this a couple of seconds just to see where everyone is. It's going to bounce around quite a bit here, but that's intended, and then we will read out. So it looks like the CDC is by far the largest, which is good to hear. And it looks like Fox News is number 2. We have everything on here for those listening on the phone, from Twitter to Reddit, to social media, to Johns Hopkins, to medical professionals, to news outlets, to other types of platforms on social media. So again, this just gives a way just to show where people are getting their information. And we'll leave this up for a little bit as I turn it over now to Dr. Meissner. So again, if you have questions, please use your GoToWebinar control panel question, and I will ask those at the end. So Dr. Cody Meissner, I'll now turn it over to you.
Okay, thank you, Rich. And hello to everybody this evening. Thank you very much for finding the time to listen in. And I guess I have to begin by saying that my favorite pizza topping is anchovies, and that wasn't one of the options, which was disappointing. But I was very encouraged to hear that the CDC is the largest or the most common source of information, because that means that everyone is accessing the most reliable, up-to-date, and accurate information. So I thought I'd just begin by making a few comments about this disease. It's a very interesting time. It's somewhat reminiscent of the influenza pandemic of 1918, and it has really turned everyone's life upside down. It turns out that the virus that causes this illness is called a coronavirus. And as you probably know, it's called the coronavirus because if you look at it in the electron microscope, you can see that it has a crown around the virus. And the first person who described it thought that would be an appropriate name. There are 4 coronaviruses that we know and have known about for years that cause the common cold. It's no different than a rhinovirus infection. And we've all been infected by coronaviruses at least once. But something changed in December of 2019, just a couple of months ago. And a coronavirus that did not infect humans, but did infect bats, underwent a mutation that enabled the virus to infect humans. And these sorts of mutations probably happen all the time and have been happening since human history began. But what's different about this particular virus is that, number one, there's much more population density in the world, particularly in China, in Wuhan, China, where this virus began. And then secondly, there's a great deal more international travel from one country to another. So this virus spread very quickly and much faster than other pandemics, such as the plague or smallpox. So all of a sudden, we've been confronted with this virus to which no one in the world has immunity, which is one of the requirements in order to get a pandemic. That is, there has to be a new virus against which we do not have immunity, and that enables the virus to move from one person to another person. And different viruses have a different capacity to cause disease, and if we'll talk about that in a little bit. I think one of the characteristics of coronaviruses are that they have a lipid envelope, and that's important because we may get into a discussion about purification of plasma-derived products. And so this virus is readily inactivated by some of the steps that are utilized in the preparation of a plasma-derived product. There likely is a viremic phase, that is a period during illness when this COVID-19, this virus, is present in the blood. We don't know how long that is. It's probably quite a short period of time for most people. But I think the risk of transmission from a blood product is extremely low, and it has not occurred previously. So what do we know about this virus? It's been difficult to get much reliable information because the Chinese government has been quite secretive and has not been open to sharing the information, the reliable information that they may or may not have. But we know that the virus has been circulating in China at least since the beginning of December. And it seems to me it's quite possible that it was months before that. But at any rate, it was announced to the World Health Organization on the last day of December of 2019 that they had isolated this new virus, which was causing pneumonia and severe disease in some people. It is, I mentioned the fact that there are 4 known coronaviruses, and then there are 2 other so-called novel coronaviruses, that is COVID, in addition to COVID-19, that is MERS, the Middle Eastern respiratory syncytial virus, which was primarily acquired from camels. Turned out that when people went back and looked, it turned out that camel drivers and people who spent time around camels all had antibodies to this virus. And then there is a second virus, SARS, severe acute respiratory syndrome virus, and that, similar to the present virus that we're talking about, began in China as well. And I think these viruses probably originate in China, or have a tendency to originate in China, because of the density of the population and the fact that humans live very close to animals. These are viruses that begin with animals, originate in animals, and circulate as far as we have known for centuries, and then all of a sudden, as I mentioned, acquire a new mutation. So let me just make a couple of comments about the disease. The disease is transmitted, first of all, by respiratory secretions. So there are essentially two ways that anyone can acquire an infection by coronaviruses. One is by respiratory droplets. That is, if a person who is infected coughs or sneezes or even talks or undergoes any sort of an aerosol generating procedure such as intubation or suctioning, then that generates small particles of saliva that contain the virus itself. And those particles, those respiratory particles, travel probably up to 3 feet, maybe in certain circumstances up to 6 feet. But as far as we know, this virus does not travel further than 6 feet away from an infected person. And that's where the whole concept of social distancing comes from. If you are at least 6 feet away from a person who may be infected, then it's very unlikely that you will become infected, even if you're susceptible. The second route by which viruses that are spread by respiratory droplets, and in this case the coronavirus, is if one coughs or sneezes or blows your nose, then there are secretions that are coughed up or you get on your hands. And if a person who's infected gets those respiratory secretions on her or his hand and then touches a doorknob or a telephone or a pencil or change, it's very likely that a small amount of that virus is left on those, what we call fomite, those objects. And then if a person who's susceptible comes along and opens that doorknob, even though you can't see any respiratory secretion on the doorknob, you get it on your hands. And we all tend to rub our eyes or touch our nose or mouth. And so we do what is called auto-inoculate ourselves. And that's why it's so important and to wash your hands. I think this has been drummed into all of us very extensively. And soap and water is clearly the best way to wash your hands. The CDC emphasizes a 20-second hand wash with soap and water. If you can't use soap and water, then a alcohol-containing product such as Quell or Puracell, is an acceptable. Calstat is an acceptable alternative because the alcohol inactivates the lipid envelope that surrounds the virus. So I think you can be confident that those alcohol products, which should be at least 60% alcohol, will pretty effectively eradicate the virus, so that when you touch your eye or your nose, you won't inoculate yourself. So just to repeat, the important point are stay at least 6 feet away from someone who's got an infection. And that incidentally is true for most respiratory viruses, such as influenza. And then secondly, you can't wash your hands enough. It's a good idea to wash your hands on a very regular basis if you've been out in public. So is that enough, Rich, or can I say a few words about the disease?
Yeah. Please go ahead. And say a couple of more words about the disease, and I'll just use this opportunity for those that have questions. In your GoToWebinar control panel, you may have to open it up using the arrow, but there is a question function. We have a couple of questions that came in that will hold to the end, but please type those in, and I will start organizing them. Again, in your GoToWebinar control panel, send your questions along, and I'll start organizing them. But by all means, please say a little bit more.
Okay, thank you. So we still know very little about the extent of this disease. My personal sense is that many of us have already been infected by COVID-19. The vast majority of individuals who are infected have very minor symptoms. I think that at least 80%, and that may be considerably higher, at least 80% of people who are infected just have the sniffles, a runny nose, maybe a sore throat, cough, but not even enough in the way of symptoms to bring you to medical attention. So we don't know the exact answer because, again, the data coming out of China was based primarily on symptomatic people. We don't know we know how many people were hospitalized and how many had severe disease, but we don't know how many were infected. China has given us the data among infected people and how many of them ended up in an ICU, but almost certainly there were hundreds more people who were infected and who never came to medical attention because they didn't feel sick enough. And so these figures that I'm citing right now are probably not very accurate, but that's the data that the CDC is working on until we can get some more information. So about 80% of people will have symptoms that are so mild, it's the sort of symptoms that we all have periodically and just kind of work through. Then there's another group of individuals, something around 10%, maybe 15%, who have rapid breathing, who have high fevers, who may have a headache, who have muscle pains and joint pains, and may have diarrhea because this virus is probably excreted in the stool like other coronaviruses. And they may seek medical attention, but are unlikely to be hospitalized. And then there's another group of around 5 to 10% who may be hospitalized, and then a small fraction of that number who require intensive care in an ICU. So I think it's important to make a couple points here. First of all, there is no reason to think that children or adults who have a bleeding disorder are at increased risk of acquiring COVID-19. I think if they're receiving the recombinant product, then this is really not an issue. And if they're receiving the plasma-derived products, one of the products, then again, I think the steps that are now used for the development of blood products are so efficient that it's not very likely that the coronavirus would survive. And I think it's also a very brief period of viremia with this particular virus. It's not like some other viruses, like hepatitis B, for example. I think it's going to be a very brief. So the likelihood someone would give blood while they're viremic, I think, is exceedingly rare, and any virus would have been inactivated during the preparation of the product. So I'm very comfortable reassuring everybody that there is no increased risk of acquiring COVID-19 if one has a bleeding disorder. If one has, and you know what, I'm going to let Dr. Rosenfield address one of the questions. Cathy, I don't know if you want to take this on now in relation to antibodies and blocking factors.
Cody, I'll be happy to do that, but can I ask you a quick question before we move on to that?
Yes, surely.
Can you comment briefly on measures that are being taken with regards to treatment?
Yes, and that's a very complicated question. Treatment, I think the first point I'd say is there is no proven form of treatment for any of the coronaviruses. We simply don't know how to treat them. So if a person becomes ill, then it's supportive care that is necessary to carry the patient through the illness. And I will say that based on data in the United States, coming from the CDC and from personal conversations with people around the country, I don't believe there's been a single person under 20 years of age who has been hospitalized because of COVID-19. And there certainly have not been any deaths. And there's no evidence of use or need for an intensive care unit in anyone under 19 to 20 years of age. The risk is at the other end of the age group, as I think people are well aware, and the risk is for people who have underlying heart disease or who have emphysema or some type of chronic lung disease. If a person is immunocompromised for one reason or another, it's not really clear that they have a worse outcome than anyone else. But we don't really know the answer to that. Certainly, if someone is taking steroids or some type of immunosuppressive therapy, I would advise them to be extremely careful to avoid infection. I don't think that such a person would be at increased risk of acquiring the infection. I just worry that an immunosuppressed person who becomes infected might be at risk of more severe disease. So we're hearing a lot about Plaquenil or hydroxychloroquine. I think there are no data that suggest this drug is going to be helpful. There is a new drug that is undergoing clinical trials and that we are investigating here at Tufts called remdesivir. that was developed for the Marburg virus and for the Ebola virus. We don't know how well it works in any of those diseases. There are a number of alternatives that are being explored, but I think they should only be used in a clinical trial, in a so-called placebo-controlled, double-blind, randomized trial, because that's the only way to really address whether or not these work. And I think we're a long way away from having that, although the federal government is working really overtime to try and get these trials initiated and started. And also I'd say that private industry, it's just remarkable how much and how quickly private industry has done. This is, our country has the best public health program in the world. We have the best physicians. We have the best pharmaceutical companies. And I think that before too long, we may have some type of approach. I think a vaccine is a little ways away, but we will soon have a vaccine. So I don't know if that answers your question, Cathy.
Yeah, Dr. Meissner, I think that is great, and we're getting a flood of questions specifically about bleeding disorders. So, Dr. Rosenfield, if I can have you go, and I would like to do the format of answering the medical side, and then there's questions that have come in specifically about insurance and policy and treatment shortages, question mark. Miriam, I'll then wait to have you go if that's okay for a format. And then I just want to address, someone asked how many people are on the webinar. We currently have 82 people that are on the webinar. So I will have Dr. Rosenfield to please go forward, and then I'll ask questions to both physicians.
Okay, thank you, Rich. I want to thank everybody for participating and listening, and I want to thank Dr. Meissner for his overview of COVID-19. I always learn something new when I listen to Cody give information, so thank you. I also want to say that Dr. Meissner was talking about the influenza pandemic of 1918. He may remember that. I personally don't. So that's one I
remember it well. I remember it well, Cathy.
But in terms of the effect of COVID-19 on the bleeding disorder community, I want to make the point that just because you have a bleeding disorder, whether it's factor 8 deficiency, factor 9 deficiency, von Willebrand's disease, factor 11 deficiency, it doesn't matter. Just by virtue of having a bleeding disorder does not put you at higher risk for being infected by the COVID-19 virus, or necessarily having a more severe infection if you are infected with COVID-19. I think it's important to realize that the community follows the same types of guidelines that the CDC has put out for the general community, that individuals of an older age are at higher risk for having severe infection, that individuals with comorbidities, meaning they have underlying lung disease or cardiac disease or endocrine disease like diabetes, or malignancies, and so therefore are on drugs that affect their immune system, are at higher risk for having more severe disease. But in general, an individual with a bleeding disorder is not necessarily at higher risk for being exposed or for developing severe disease. There are some caveats to that, in the sense that if you happen to be an older individual with a bleeding disorder, then yes, just like anybody else who's older, you may be at higher risk for having more severe disease. or if you happen to have not only factor VIII deficiency, but severe lung disease, that is going to put you at greater risk. And lastly, if you happen to be on immunosuppressive drugs for any variety of reasons, you also would be at higher risk for having more severe disease if you were infected. Somebody asked the question about patients who happen to have inhibitors. So someone with factor VIII or factor IX deficiency who happen to have an inhibitor to factor VIII or factor IX, and their risk for COVID-19 or their risk for severe disease. And again, it speaks to whether they are on medications that could affect their immune response to the virus. So if you happen to be on rituximab or CellCept to try to decrease your immune response, then yes, you may have more of a problem responding to a viral infection. The majority of individuals who have inhibitors are not being treated with immunosuppressives, but some are. And so those individuals, again, not because they have hemophilia or they have an inhibitor, but because of the drugs that they're on, would be at higher risk for more severe disease. I do want to re-emphasize what Dr. Meissner had said about purity of the blood supply, and I think that Miriam is going to talk about this as well. The blood centers who are collecting, who collect blood for just general blood donations have put into effect more regulations with regards to blood donation. If you have traveled outside of the country, if you have been to states that have high incidences of COVID-19, if you've been exposed to somebody with COVID-19, if you are ill, you have fever, runny nose, cough, they will not allow you to donate. And they actually ask you to wait 28 days. And that's their way of trying to prevent any further problems with any donations within the blood supply itself. But again, even more importantly, we have found historically, because of what has happened before within the concentrates that we use for treating bleeding disorders, that the pharmaceutical companies have put into effect a number of different procedures that have led to purification of most viruses, and particularly the lipid envelope viruses, which is coronavirus. So heat pasteurization and solvent detergent preparation and nanofiltration all serve quite well in eliminating viruses from those plasma-derived products. And I know Miriam's going to talk about that more. The other thing I want to mention is if you happen to have a port and therefore are at risk potentially for infections related to the ports, this is no different in this day and age than it was 4 months ago. If your center requires you to call because you have a fever and you have a port, then you still need to call because you have a fever with a port in place. It doesn't mean you have COVID. It means that because you have a port in place, you are at risk potentially for a blood infection related to bacteria from using the port. Also, if you are scheduled for your routine visits at your HTCs or hematology clinics, you do need to touch base with the clinics because many of the hospitals are trying to conserve on resources and are asking non-urgent appointments to either be postponed or to be done through a telehealth format where you actually use Skyping almost, FaceTime to talk with your physician and to have your appointment. So I would encourage people who haven't heard from their centers and are due for appointments to touch base to find out how they want to proceed with those appointments. And then the last thing that I want to say is if you're ill, if you have fever and cough, respiratory symptoms, sore throat, diarrhea, and you're concerned that you might have COVID, COVID-19, that you should be contacting your primary care physician, not your hematologist necessarily, to talk to them about being seen and or tested based upon your symptoms and the potential for exposure. And again, it really is based upon what your underlying medical illnesses are and also what your symptoms are.
Fantastic. Thank you so much, Dr. Rosenfield. So what I'm going to do now, before I turn it over to Miriam, I'm grouping the questions of medical, and then we'll go into the policy side of this. Given the time, I do expect this webinar to go a little bit past 8 o'clock. It is being recorded, so we will do our best to go through the questions. So Dr. Meissner and Dr. Rosenfield, I'm going to ask these to you, and if you can answer them the best that you can so that we can answer as many of these questions. The first question is, some people cough up blood as one of the symptoms. Is this a worrisome for anyone living with a bleeding disorder?
So I would be concerned about how much blood is being coughed up. Sometimes you can have just irritation in the back of your throat, so that when you cough, you'll have a small amount of blood-tinged sputum. But if you're actually coughing up a significant amount of blood, that is worrisome, and that's related to not only the inflammation that's occurring, but also how easily you're able to control any bleeding associated with that inflammation. Hopefully, if you are on prophylactic infusions, that's going to prevent you from having any significant bleeding. But again, much like having a bad muscle bleed or a joint bleed, if you have a significant amount of blood in what you're coughing up, you need that needs not only to be treated with in terms of that needs an infusion, but it also needs to be addressed with regards to why is that happening.
Thank you. The next question is, in terms of treatment, there have been some talk of blood transfusions with exposed and recovered patients. Do you see this being realistic or effective based on the limited information we have?
Yeah, I can take that one. This is Cody Meissner. Again, there have been some anecdotal reports of using the plasma from people who have survived COVID-19 and infusing that into people who are sick. In short, providing the antibodies that the sick person is unable to make. I think that there are so many hazards that associated with doing that I would be very cautious. We know that intravenous immune globulin sometimes has a role, but intravenous immune globulin is used primarily for prophylaxis, that is, prevention of disease, such as with rabies or hepatitis B, not used to treat disease. So I don't anticipate that will be a very useful approach.
Okay, great. Dr. Meissner, I think this one is for you. There's several questions about a point that you said about kids under the age of 18 being at risk. It looks like there's a healthcare provider on here that says, I've seen for a fact there's been multiple hospitalizations of children requiring ICU and mechanical ventilations. Another comment that says there was a death in LA of a child under the 18 due to COVID-19. And then another question that says, if young people aren't at risk, then why are we seeing reports that more young people are being hospitalized than have been expected? So maybe you can clarify a little bit of the risk of those under 18 with no underlying health condition.
Yep. Thanks for that question. Well, I can refer people to the monthly and morbidity weekly report, which is a report that's free, and I can get it online from the CDC. And I'm looking at the March 18, 2020 report, and they looked at 2,500 people, and there were no ICU admissions, no fatalities, and almost no hospitalizations. So I think I'm not sure what source the people were looking at who said that there have been multiple children on ventilators. I don't believe that's accurate. Certainly, there will be deaths. That doesn't surprise me. Remember, and just to kind of put this whole issue in perspective, there are probably 26 to 30,000 deaths so far this year in the United States due to influenza. And most of those are in people over 65 years of age. Last I saw, there were 145 deaths in children. So, and those occur primarily in children who have associated comorbidities, as Dr. Rosenfield said, who have other risk factors that impair their anatomic or immunologic immune function. But and certainly there will be some children who get sick and who die from COVID-19. I mean, that's true for any virus. But I don't think the statement that you read, that there are multiple children on ventilators, is an accurate statement. Remember, there's great anxiety and even hysteria, and the internet is a very unreliable source of information, and that's why I applauded those. I think, can't remember what percent it was, but most people said they acquired their information from the CDC. And just to tell everyone, that website is www.cdc.gov. And the federal government is doing a fantastic job to keep the data accurate at that site. And so I would suggest you rely on that as a source of information rather than newspaper reports, because that's just not an accurate statement that there are many children on respirators. It just maybe in some other country, although the reports from China are the same too, that there was very little disease in children. So I don't think that's an accurate statement.
And I appreciate you saying that, because that's why this format is happening. That as we all know, things are changing daily. The reports are being updated. So I think that as sources are being shared, there's a lot of unknown and there's a lot of known. So I think going to those reports that you're sharing and reading the articles as to say that these are the facts, and not to say that it's not happening, but just understanding as to where this information is coming from. Another group of questions that came up is about those living specifically with hemophilia, HIV, and hepatitis C. Are they at higher risk, is the first question, with an undetectable viral load. So the question is, HIV, hemophilia, hepatitis C, are they at higher risk even if they have a undetectable viral load?
Yeah, I can take a first attempt at that, and then maybe Cathy may have may want to add it on. I think, and that's an important. And when you say they have an undetectable viral load, I assume they're talking about HIV, and I'm not sure if they're referring to an undetectable level of Hep C, but as far as we know, if people have normal T cell subsets or relatively normal T cell subsets on antiretroviral therapy, their immune status is pretty good. And they don't have a normal immune response, but it's pretty close to it. I think as long as they have a reasonably appropriate number of helper T cells, I do not look at them at increased risk of acquiring infection. I would be concerned a little bit more about the risk of a more severe infection. But again, I think the important point is, since there isn't any treatment and there isn't any vaccine, the best approach that we can all take is don't expose yourself. Try not to get into a situation where someone's likely to cough on you, because if you remain at home, inside, dull as that can be, although Netflix certainly helps, you have to be exposed to someone who's contagious in order to get this infection. And so if you practice good hand hygiene and you avoid having people sneeze and cough on you, I wouldn't go on the subway, for example, or and the airline industry is being devastated, but I think it's important. I would not encourage anyone to fly on an airplane these days. It's probably safe, but it doesn't make a great deal of sense.
Great. Thank you.
I would agree with,
go ahead, Dr.
what
Rosenfield.
Dr. Meissner said. Yeah, no, I would agree with what Dr. Meissner just said. And again, prevent it, the old adage, an ounce of prevention is worth a pound of cure. Just trying to avoid putting yourself in situations which will increase your risk is probably the most important thing that you can do.
Thank you. Dr. Rosenfield, you've been practicing hematology for a couple of years, and this question I'm going to ask you to address. There is a patient living with HIV and is worried that if they contract this, are they going to be shunned like they were back in the 80s and 90s due to their HIV/AIDS status? And what are your thoughts around that, having a repeat situation of this happening?
It's interesting. There was an article on the front page of the Globe yesterday, I think, or the day before, of a woman who was exposed and contracted COVID-19 and was ill, and then needed to notify everybody she had been in contact with that she had the virus and that they needed to be aware of the fact that she had the virus. And she talked about the guilt that she felt and the shame. And I think that is unfortunate, and I really hope that we are not going to put our community through that type of emotional stress again. This is not anybody's fault. This is a virus. Anybody can be exposed to it. Anybody can contract it. There's not a lot that you can do except try to prevent by trying to enact the preventative measures with good hand washing and avoiding public places that you're going to put you at more at risk. But I certainly hope that we are not going to do that again. And I don't think that anybody that's just not something that I hope that we're going to go through again. And it's not something that anybody can absolutely prevent happening, whether you have hemophilia or you have any other underlying comorbidity that would increase your risk. But unfortunately, I think people are feeling that way because of all of the media hype that's going on right now, but I really hope that we don't do that again.
Yeah, I mean, I would just add, this is Cody Meissner again. I completely agree with Cathy. I mean, remember, every hospital in Boston has patients with COVID-19, and it's everywhere. And it's no different than influenza. I mean, people don't feel guilty when they have influenza. The only reason they should feel guilty is if they hadn't been immunized against influenza. But it's not. I actually was quite interested in that question. I was surprised. Because that we all take care of patients with COVID-19, and I'm just. It's odd that someone would feel guilty. You can't feel guilty about catching a cold.
Yeah, and I think that this comes back to what this community went through in the 80s and 90s, especially with this question. So I appreciate you both being so thorough in those responses. I'm going to ask a couple more medical based before we turn it over to Miriam, since we're right around that 8 o'clock hour. What are the risks for women with bleeding disorders in their 30s? How can COVID-19 possibly impact a pregnancy in the bleeding disorder community? So I think there's two questions here. What are the risks for women, if there are any, with a bleeding disorder, and how can this impact a pregnancy for women that may have lowered factor levels?
Let me go first, Cathy, on this, because I spent some time thinking about it, and then you can maybe address the bleeding aspect. The data that came from China, again with a caveat that it's of limited reliability, is that infection in a woman who's pregnant is no different than in anyone else. And however, that's with the restriction that we haven't known about this virus for very long, so it only pertains to the third trimester. We don't know so much about COVID-19 in a pregnant woman if the infection occurs in the first or the second trimester, because we haven't known about this virus long enough. And as we mentioned earlier, there probably is a viremic phase for at least a short period of time. And there is a theoretical possibility that the placenta could be infected, although there are no data to suggest that any damage or abnormality occurs in the woman's baby. Now, the numbers are very small, and the world experience in this sort of a setting is very limited. So we can't be very emphatic. However, my sense is that the risk is extremely low. And again, for many individuals, it's possible to avoid exposure to this virus. And in other situations, one's profession or family arrangement may result in exposure that can't be prevented. But again, wash your hands constantly and avoid being within 6 feet of anyone who's got a respiratory illness.
And
Cathy,
again, yeah, no, I think the question truly pertains more to, does pregnancy alter your immune system enough that it would predispose you to a more severe infection with COVID-19, which you just addressed, Cody. The fact that you may be pregnant and also have an underlying bleeding disorder isn't necessarily going to change that basic question. And I don't think that the fact that as a woman who has a bleeding disorder, whether it's a low factor 8 level or factor 9 level or factor 11 or von Willebrand's, is going to impact on whether you have a more severe case of COVID-19. I think it really pertains more to the pregnancy aspect of that question.
Thank you. I'm going to see, I know this is probably a long answer, Dr. Meissner, but I'm going to see if maybe you can give a quick yes, no, or I don't know. There's a couple of questions are, once you have COVID-19, can you get it again, or are you immune?
Yep, very interesting question. As far as we know, there's only one strain of COVID-19, and I think it's quite likely that if one is infected, the likelihood of getting reinfected by COVID-19, at least within a 12-month period, is very low. And because I think your immunity will last long enough, so it'll get you through a year. Whether repeat infections can occur next season, because this virus is going to have a seasonality, just like every virus does. At the moment, the feeling is that this virus likes cold, dry weather. It doesn't do so well in hot, humid climates. And so I think many people are hopeful that this virus will begin to fade as we get into the warmer months of the spring.
Last medical question before we turn it over to Miriam, who's been extremely patient. And this may be a tough question to ask, but many patients with a bleeding disorder receive their shipment in boxes. Do they have to worry about handling the boxes from UPS or FedEx? Should they wash their hands after unpacking their medication? Should they put the boxes outside of their home? If you can give some guidance around packages coming into homes, and is there a risk of COVID-19 living on cardboard?
Very, very interesting question. And people have thought a lot about that, particularly because we get a lot of shipments from China. And I think one easy answer is yes, wash your hands. Wash your hands, wash your hands, wash your hands. I hope that's a take-home message that people get from this session tonight. All viruses live inside cells. They can't replicate or multiply on bread the way a fungus can, or the way bacteria like salmonella can. Can they survive on a cardboard box if there's a lot of phlegm or mucus secretion there? I suppose it might last. It's conceivable that it could last for up to 24 hours. There have been some studies on that, but I think there's a lot of uncertainty. But sure, on one hand, you could just leave a package untouched for a day or two, but no one wants to do that. And so, yeah, go ahead, open the package, but wash your hands. There's not going to be an aerosol generated from a package. It's going to be the second route that we mentioned at the beginning of direct transfer from the box to your nose or your eyes. So unpack and wash your hands. I mean, that's you should be washing your hands a whole lot these days.
Great advice. So with that said, Miriam, I have put up on the screen, I'll just show people where to go if they go to the hemophiliafed.org, and this is also can be found on the NEHA website homepage. There is a coronavirus news and resource, and I'll turn it over to you to just give a little bit of overview, and then I'll ask a couple of questions that have come up that I think pertains to you in particular.
Sure. Thank you so much, Rich. And thank you to Drs. Rosenfield and Meissner for your presentations tonight, and also for all you're doing for patients and public health throughout this period. I think to get to the questions, which are the really important piece, I'm going to just very briefly introduce what the resources that HFA has pulled together on the website. We've made this coronavirus hub, which, as Rich showed, you can get to from the HFA front page. HFA was trying to anticipate and respond to questions that are important to people with bleeding disorders. The hub is regularly updated, so revisit frequently, and most of the material is available in Spanish. There is a button there at the top. So if that is relevant to you or to people please point that out. I will just highlight a couple of things. One is the information that's showing right now about industry news and product availability. This addresses a key concern that we've heard from people with bleeding disorders about, will our medications continue to be available? And as you can see, we have statements from basically all of our manufacturers saying, yes, they do not foresee any disruptions to supply right now. We have heard the same from our specialty pharmacies. And further, we've heard from specialty pharmacies that they have contingency plans in place to be able to distribute medication and supplies. And they are considered by Homeland Security guidelines to be part of essential critical infrastructure. So that means that filling orders and shipping orders and delivering orders will continue to happen even in the event of a lockdown. We do link to PPTA and to FDA statements about the safety of plasma-derived therapies, as both Drs. Meissner and Rosenfield mentioned. And then at the very bottom, if you want to scroll down, Rich, we have a section talking about insurance coverage concerns in a time of great economic upheaval. And so there is, there at the bottom, that little graphic insert, Rich, if you click on it, that will call up a PDF of that can kind of walk you through if, unfortunately, you have lost your job, are you eligible for Medicaid, or under what circumstances would you go to the marketplace? And so I'm happy to talk about those issues. I will raise one more thing before we go to the questions that Rich has, and that goes back to the issue of product supply and availability. We've been asked a lot about keeping extra factor on hand, and the bottom line is that this is neither a time when patients need to ration, nor is it a time to stockpile. And so, it may be appropriate to keep a few extra doses on hand above the cushion that you ordinarily keep of clotting factor or other bleeding disorders medication. But our medications are not in the category of blood pressure medications or something else where it's appropriate to keep a 90-day supply on hand if that is not your regular order. So with that, Rich, I think it's probably best if you it makes best use of our time if you want to go through some of the questions you got.
Sure, yeah. So thank you, Miriam, for going through this. This is a great resource. So on the NEHA page, you can find a COVID-19 update, which links to this. But I think this is a great one-stop shop that goes through everything and is being updated, as Miriam said, throughout. But one of the questions that came up, Miriam, is someone had mentioned that in a lot of these statements, it uses "at this time." Can you talk about if companies are issuing these statements as of March 21st, as of March 16th, are they speaking at this time, or is this for the foreseeable future that they don't have any problems with products or ancillary supplies?
They are telling us it's for the foreseeable future. I think their statements always have to go through legal, but really they have assured us they do not foresee problems in supply and disruptions to availability.
Great. Thank you very much. Someone had mentioned about insurance, about being laid off from their job and insurance, and I think you addressed where some of those resources are. I don't know if we wanted to mention anything else about if you are laid off from your job and you lose insurance and your employer is not providing insurance anymore. Maybe you could touch upon that of what is available.
Yeah. So one thing that I'm happy to say is that Medicaid expansion is available in all the New England states. That means that the Medicaid program of your state covers adults with low income, regardless of whether they're disabled. This is not true of all the states across the country. There are 14 states that have not, quote unquote, expanded their Medicaid programs. But so that is an option, and it is available to you based on your current monthly income. So if you have lost your job and you currently have no monthly income or just a small amount of income from perhaps a side job that you had, we advise you to make your first stop the website of your state's Medicaid program. So Google New Hampshire Medicaid or Rhode Island Medicaid. It will walk you through. It is unfortunately a multi-step process. You have to enter a lot of information, but that is a great resource. Medicaid is available only to people of incomes under 138% of the federal poverty level. And again, that's on a monthly basis. So if you are perhaps in the position that your hours have been cut, but you haven't lost your job, or one member of the family has lost their job and the insurance was attached to that, but another member is still earning, and so you're above the poverty level, then you would want to go to healthcare.gov and look at your options on the ACA marketplace. And it gets a little confusing here because most people who buy insurance on the ACA marketplace are entitled to subsidies to help afford the cost of that insurance. And that is, again, dependent on your income. But there they calculate your income on a yearly basis. So unfortunately, it's a convoluted structure. The good news is that hopefully there is a resource for everyone between Medicaid, between the ACA marketplace, and it is just a matter of dotting the I's, crossing the T's, jumping through the hoops, mixing your metaphors, and gathering all the information you need to go through the process to qualify for one of these forms of coverage.
Thank you, Miriam.
The PDF that, sure, and the PDF that you showed, Rich, also talks about COBRA, which is another option. That is where you lose your employment, but you are entitled to continue on your employer's plan. COBRA, it tends to be an expensive option because you have to pay 100% of the premium. While you are working, your employer may have been covering part of the premium. But that may be an option that makes sense for you. We just want you to explore the other options that are available and weigh them and know what might be best for you. One last thing, I wanted to point out that this resource about insurance coverage is a joint HFA and NHF product, and the contact information for both organizations is at the bottom. And if you have questions, please contact either or both of us.
Thank you, Miriam. This question is not meant to be political, but it was asked, and I do think that the physicians and Miriam, I would like to address it since we're in a social media frenzy. My neighbor keeps telling me that the coronavirus is a political scheme to try to put down President Trump. Is this true?
Well,
I don't know who would like to answer that.
As a resident of Washington, D.C., and someone who works on policy matters, I will say 100% no.
Yes, and this is Cody Meissner. This is a real worldwide pandemic, and it began in China, and the Chinese were not honest in revealing the origins and the extent of disease, and we are now encountering severe disease here in the United States, and I think that some political parties may be trying to use this national emergency to their own benefit. That's the way politics works in this country and everywhere. My personal feeling is that the Trump administration did exactly the right thing by preventing travelers from coming in from China. Again, that was a type of social distancing, and the present administration really was attacked by the press and others for limiting travel into the United States. There's nothing racist about what's going on. This virus has no respect for boundaries of countries or nationalities. This is a global pandemic that, if you listen to the TED Talks, Bill Gates 3 years ago very accurately predicted. I think my personal opinion is the federal government is doing an extraordinary job in the most that anyone could expect in an effort to end this pandemic and to support families and businesses that have been placed in a unique situation. So I always try and take the politics out of this. The politicians, of course, try and put it back in. Everybody wants to negotiate it to their advantage, but I don't think anyone else has any better answer for how to deal with this.
Thank you both. I think it was brought up here, and for those listening, just making sure. I think this is given a forum to ask these questions. A couple of questions, and I do want to end this. I think we could probably go even later, but let's end this at the very latest in 5 minutes. There's a couple of questions, Miriam, of people that are just confused by their options. If it's okay with you, I will connect you guys offline. They're just a little confused about the website and about the insurance PDF. So if it's okay, I'll just start an email between the two of you.
Sure, that would be great.
Okay, great. Miriam, if you can address the bill that was passed last night, what is in it for Americans who may have been laid off from their job? Any high-level information that I know most can find out there, but if you can just give a brief overview of what you know from it.
I can't give a whole lot because it is still, they passed it first and they're writing it second. Uh, so they agreed on broad outlines, and the last thing I saw before I joined on the webinar was that there was a hiccup, and maybe there were people, there were senators expressing some concern. So I'm afraid stay tuned. We will be posting information soon, but I am worried that any information I give you right now would be inaccurate.
Great answer. Thank you, Miriam. These are other questions that I'm hoping in the next 2 minutes we could do rapid fire, just to try to get through all of them. Dr. Meissner, there are no known treatments for COVID-19, correct right now?
Yes, that is a correct statement.
Yep, the question was, yep, go ahead.
Yeah, I was just going to say I would caution people not to use any. I mean, people have talked about vitamin D and steroids, and it's important not to use any untried therapeutic remedies. Because there are none.
Great, thank you. Yeah, the question was, are treatments for COVID-19 safe for those living with hemophilia? And I think the answer is there are no known treatments, so therefore it can't answer that since there are none. The other question is it true that the virus infection can lower blood platelets?
Is it Cathy? Yeah.
Well, I mean, any viral infection can potentially lower your white blood cells and your platelet count. It's part of how a virus affects the bone marrow, but it isn't specific to COVID-19. That's just true in general with viral infections, and it doesn't always happen.
The next question is about if a person is over 60 and they have no underlying health conditions or comorbidities, why are they at higher risk? Why is the media and the CDC saying anyone over 60 is at an increased risk, even if they don't have any underlying condition?
Well, I think the answer is that most of the deaths that occur, and we don't know what the mortality rate is because we don't know what the denominator is, as we talked about earlier, but most of the deaths do seem to be occurring in individuals who are over 60 or 65, and and they seem to be occurring in people who have heart and lung disease. If you don't have that problem and you're in an older age group, that's wonderful. And I think if you were to be infected, you're more likely to have an excellent prognosis. But again, if you want to look at the data, the most recent data, the MMWR on the website I mentioned from March March 18 of this year has that data.
Great. Thank you very much. The last question is someone that works for a company, and they said that their company, who is a pharmaceutical company, had placed a letter to the FDA, and I'm probably not going to say this right, Octaplase, OCTAPLASE, to formulate as a potential treatment. They were just curious, have you heard anything about this type of drug being used as a treatment or a vaccine?
I have, yeah, I've never heard. I don't know what Octaplase is. I've never heard of it. So I cannot comment.
Okay, thank you. Perfect. Well, I cannot express enough of gratitude to the three of you. You're both incredibly busy, especially you, Dr. Meissner and Dr. Rosenfield. You're on the front line in the hospital day in, day out. there were several questions and comments of the amount of thanks for spending the evening with us and for what you're doing. And several comments too about making sure that you all stay healthy and don't burn out, and make sure that you're taking self-care, exercising, eating well, all the things that we're being told. So I again, just on behalf of NEHA, thank you so much for taking time and spending your evening with us. Just a couple of other housekeeping things. For those that participated in the texting, that was all anonymous. NEHA does not know where these numbers are coming from. We're not going to spam you with anything. This was just a way to engage. So all of that was made anonymous, and your phone numbers are not going to be used for any purposes. The webinar this evening was recorded, and with the permission of the presenters, we will share this with those that were not able to be part of it, and that will go out via email and be stored on the website. As we mentioned, this is part of a series of trying to create some type of normalcy in the education forum. So next week's webinar will be at 7 p.m. and will feature Joe Schwartz from McGill University. Joe's presentation is called Sense, Nonsense, and Science, Communicating Medical Events in the Era of Social Media. So a lot of things that came up tonight will be addressed, and you'll get a link to register for that. Thank you again for our panel for volunteering their time and for your hard work. We please know that organizations like HFA, NHF, and your healthcare providers in NEHA are here for you. And have a great night. Stay safe, and please don't hesitate to reach out. Thank you again, everyone.
Thank you. Good night.
Thank you, Rich.
Thank you,
Good
Rich.
night.
Good night.